Hello, my name is John Bielenson. On behalf of the Hospital at Home Users Group, welcome to What's Needed Next, Hospital at Home during the extended waiver and beyond. A webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We'd like to very much recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. And just so folks know, the slides and webinar will be available afterwards on our Technical Assistance Center and on the events page of the Hospital at Home Users Group, hahusersgroup.org. It's now my pleasure to introduce our moderator for today's webinar, Dr. Al Su, Chair Emeritus of the Brookdale Department of Geriatrics and Palliative Care at the Icahn School of Medicine at Mount Sinai. Dr. Su.
Thank you, John, and welcome, to the 17th webinar of the Hospital at Home Users Group, led by Bruce Leff, Linda DeCherrie, David Levine, and myself, with the support of the John A. Hartford Foundation. As you know, we expanded our technical assistance for the Hospital at Home Users Group, in 2020 in response to the pandemic, and this slide shows you the various ways to reach us. And of course, you'll be getting the slide deck, in a few days as well. This is the 17th webinar that we've hosted since the beginning of this pandemic in 2020. We've also hosted a number of office hours. We've engaged an active community, that has helped answer each other's questions and that has helped one another. And we have been very proud of the work of the Hospital at Home Users Group and that we've been and the role that we've been able to play in terms of providing technical assistance to this group. This is a reminder, that we will be having the annual meeting of the Hospital at Home Users Group this fall. This meeting will be a virtual pre-conference to be held for the in-person AAHCM annual meeting in Seattle in October 12th to the 14th. So please join us either for or both the virtual pre-conference or the in-person conference in Seattle if you're able to attend. One reminder for today is that if you're interested in submitting an abstract for the Hospital at Home track, for this meeting, those abstracts are due March 13th, and there's additional information below, for abstract submissions. Today's webinar is on what's needed next. It will be a call to action in many ways. We as a community worked, really hard over the last couple of years and with many others to educate Congress and eventually leading to the passage, of the extension of the hospital, of what it had been the Hospital at Home waiver at the end of last year. We were gratified by this action, and this extension will take us through 2024. What this webinar will focus on is what do we need to do in the meantime to try to finish the work that we started with this extension. Speaking on this topic today will be Linda DeCherrie from Medically Home, previously at Mount Sinai, David Levine from the Brigham and Women's Hospital and Harvard Medical School, and Bruce Leff, from Hopkins. In addition, we will be joined by our partners at Healthsperien, Ray Quintero and Aaron Ledbetter, who will be speaking to us, shortly. Over the course of the remaining hour, we will present to you our summary of what we need to do as a community going forward to institutionalize hospital at home in our hospitals, so that by the end of 2024, when Congress takes up, what to do next, hospital at home will be too important and valuable to do without. And so we will be going through, a number of topics today, including, understanding the waiver's future and educating the Hill. We will be joined then by Bruce to talk about program standards and span codes, and related to that, contributing quality data that we think will be important going forward. David, and I will be talking about the need to publish your data and to collect anecdotes to make our work known to the public, and what we need to do, to be a good actor. And Linda will bring up the end with talking about the need for us to push for contracts outside of Medicare and to act on equity and on issues related to supporting our caregivers. These are all the things that we need to do to show by the end of 2024 that hospital at home is too important and too valuable to do without. This community got the extension done. Let's see if we can rise to the challenge, of finishing the job in the next 2 years. In the next section, Healthsperien will take us through the first of these two topics.
Great. Thank you, Al. Well, first off, congrats to all of you on such a milestone, the waiver extension. Most off to the users group, of course, the John A. Hartford Foundation for their great support, the Academy, and the whole hospital at home community. It's a great achievement, but unfortunately, that 22 months is going to go by very quickly. There needs to be a great sense of urgency for members of Congress, also policymakers overall, to understand the important role that they need to play to make sure that this waiver extension is only a step toward what is the future of hospital at home. So now let's get to work to ensure that it doesn't go away in 22 months. Aaron, why don't we just jump in and talk about the waiver's future? Aaron?
Yes, thank you, Ray. I appreciate it. So with the waiver's future itself, some of the facts we already know, as Ray and Al have mentioned, by signing the omnibus federal spending bill into law in December, that gave us until the end of 2024, which is really a short-term assurance for the longer-term success of hospital at home. A couple of things to note here. The Medicare payment will continue at the DRG rate through December 24. And for folks state by state, you should check your Medicare rules because they might differ. And so ask your state Medicaid team for any additional information. The other aspect that's really important about the waiver as it stands today is that the participation, performance, and data will continue to be collected and closely monitored. And it's very important to make sure that this is whole because it's going to inform the future of the program and a longer-term solution to potentially provide these services through both Medicare and Medicaid. And that ensures, obviously, that patients in need will continue to receive these services. Now, some of the facts in our favor for extending this beyond the current 2-year waiver are the fact that the results of the waiver program have been quite extraordinary to date, as over 8,000 Medicare beneficiaries have been treated under the waiver. And these folks have very complex conditions that previously required hospital admission. This does allow hospitals, many of which struggle with capacity issues, to free up some of that capacity by treating these patients in their homes, and then allowing additional capacity for some of the sickest or most acute patients that are hospitalized. Now, the other and very important fact is that hospital at home aligns really well with CMS's publicly stated 5-year strategic plan of providing really comprehensive services that advance health equity for all populations nationwide, expand access to care, which hospital home does really well, and is also an innovative program that reduces both cost of care while improving health outcomes. And lastly, the point that I'd like to make is that the waivers serve many Medicaid and dual eligible populations, which aligns nicely with CMS's strategy, as a number of these populations have issues with access to care and health equity issues as well.
On the next slide, you'll see how the facts in our favor can really play in our favor, just as they did when the waiver came into the extension. So as you look at the next slide, what can we actually be doing now? There are four things that really come to mind. One is that you all continue to be the experts. You all are a powerful voice. The data and experience that you will continue to collect over the next 22 months and all the data and experience you have under your belts is going to speak volumes. And also there's an important role that you can play. One is that you're going to be able to re-educate members of Congress, those that already understand you, those that already know the great work that you're doing. It's important to continue talking to them, to thank them, to continue sharing your data, continue sharing your experience. And then those that don't know us, that don't know the great work, that are new to Congress, educate them about the importance of this program, the role that they can play in ensuring that this program, that this waiver, and that there's an opportunity for permanent payment under Medicare and beyond continues beyond 2024. In addition to that, we can engage in a collective dialogue with CMS. We're a powerful voice. We can talk to them as they determine quality and safety regulations that are required in statute based on the experience and data that you already have. And again, we can't say enough about the importance of data, which you'll hear about later on in this webinar. And in addition to that, we have to continue to build new champions that not only understand what you do, not only understand the care and the importance of it, but also support hospital at home and staunchly promote it, and staunchly promote not only a sustainable system, but also a permanent payment structure for hospital at home.
Ray, Aaron, thanks a lot. So I'm Bruce Leff, and I'm going to talk to you about two topics. One is about program standards, one is about span code. So first, let's talk about program standards. So one of the things that we've learned a lot about in our conversations with multiple stakeholders related to hospital at home is that we'll often hear, well, you know, there's so much variation between hospital at home programs. How do you know what you're actually getting? So we think it's really important that hospital at home provide high quality care and that there's a clear definition about what programs are providing, how they're structured, how they're set up, what their procedures are. And we know that there's been a lot of interest in this from multiple stakeholders in our conversations with organizations like CMS, like the Joint Commission, like the NCQA. And we've always had the point of view that program standards should have substantial input from our community so that they're not simply imposed on us by people who don't necessarily understand hospital at home model, hospital at home operations, hospital at home delivery. So we, as a users group, undertook a pretty extensive process to develop those program standards with substantial input from the community. And on the next slide, just to outline what that process was, the users group started in 2020 and 2021. There was a program standards work group of the users group. We had a lot of conversations about program standards, the purpose of those, what they should generally look like. We developed a draft set of those program standards. We had a comment period among the work group. There was work group iteration, had input from the larger hospital and home user group community. And then last year, we developed a final set of version 1.0 of program standards. And then we were hoping to get a survey of active hospital at home programs to attest to how their program matches up to those program standards. This is an absolutely anonymous survey that we would like to do. Our goal is to have a single survey response from each active hospital at home program in the country, so that then we could actually describe to stakeholders like CMS and the Joint Commission what our programs look like and how they're actually doing. So to date, we've been trying to solicit and identify a single person at active programs to complete the survey. So far, we've only had about a quarter of active programs that we know of that have identified such a person. What we'd like to do is have that move up towards 100%. And also just to let you know that the survey itself is really quite easy. It'll only take about 15 minutes. You don't have to do any data digging. If you know your program, you should be able to answer these questions quite easily. So there's a link at the bottom of this slide. You'll see it again, along with a QR code on a slide towards the end of this presentation. And we'll also be sending out these links to user group members on Basecamp, and they'll be posted on our website, and we'll also probably reach out by email. But we would love to get this this number up, get these surveys completed, and be able to talk to stakeholders about what our programs look like and why payers and the like should be investing in them. I'm going to switch now to span codes, which is something I never knew existed until getting involved in this work in the context of the waiver. So the user group, we actually succeeded in obtaining approval for codes. These are billing codes that all the people in the back rooms of your hospital and in the coding shop know about, but which I didn't. And we got approval from the National Uniform Billing Committee for one span code and one revenue code. So these codes become important in making it easier to facilitate claims analysis by CMS and investigators about hospital at home. Right now, CMS can identify hospital at home treated patients when data gets submitted on waiver patients because you're providing Medicare identification numbers. But right now, we estimate that only 50% of patients cared for under the waiver are using these span codes. So we would love to have all programs using these codes on all of their patients. And the key action step here is to inform your revenue cycle personnel about the existence of these codes. And on the next slide, you could see a screenshot on the left from the National Uniform Billing Committee. It outlines what the two span codes are. In the lower right box, you see a link to that site, or if you simply Google HAH span codes, NUBC, you'll go right to those. But your revenue folks would probably be very interested in these, and we would encourage you strongly to use them. So I'm going to turn it over now to David.
Great. Thank you, Bruce. Really great to be with you all. Super excited. Thanks for being with us. So wanted to just move us on to the next step of essentially contributing some of your data to the hospital at home users group minimum data set. So we have set out on a very long journey to create a minimum data set for hospital at home patients and have involved many users group members in what that data set should look like, what variables should be in it. And we are really hoping to begin collecting that data with all of your help and have tried to make it as absolutely easy as possible. And so basically, the way that it works is we will ask for a yearly extract from voluntary submissions from various sites around the country to essentially report de-identified data. So why is this important? It's important for many reasons. One, you'll be able to look at your program compared to the national programs, right? Well, maybe what's your escalation rate compared to other programs? Or how do you vary in other factors of safety? Or maybe you take care of patients who aren't part of the CMS waiver and want to see how your data stack up. And so we're hoping to collect patients' data on all patients, not just waiver patients, but all patients. And also we're hoping to collect some safety data that you probably are already collecting as part of serious reportable events. And so we are also, similar to what Bruce said, we are hoping to keep this entirely anonymous and have worked very hard to keep it entirely anonymous, but as a result, need to identify a single person from a site who will submit data anonymously. We won't even know what site it comes from to the data set. And so we're hoping to just have one person from each site sign up to be that point person. And you can scan that QR code here or go to that short link in order to fill out just four fields to say that you'll be that person for your site to submit your data. We're happy to share the exact variables. They're pretty standard things. And we're hoping to get this off the ground in the next month for programs to submit kind of on a yearly cadence so that we can start to present these data to the whole entire community for your own programs to get better and for us to look at other payers as well. On the next slide, we also wanted to talk about an action item of publishing your data. And really the take home here is please publish your data anywhere. And so if you advance just one, I think of getting the word out about what you do as being exceptionally important. You all are doing incredible work in the trenches, in patients' homes all the time. And so kind of on the right side of this spectrum, there are the peer-reviewed options for publishing your data. And there are so many people that are now moving into this field in programs across the country. And we are so happy to see this and so proud of it, that the field is really generating a lot of data. You can send in original investigations, which are, lengthy research style papers. You can also send in tiny 600-word research letters to journals, where you just maybe describe your population, what you've done, how you've done it, in a very quick peer-reviewed fashion. Or you can write viewpoints, which are really like opinion pieces about why is hospital at home the greatest thing since sliced bread? Or how do you take care of caregivers in your hospital at home program and why that's really important? And so these are things that really anyone can do. And sometimes take a little work the further to the right on this continuum you are. But there's a lot of other opportunities also. And so looking at some of those additional opportunities, there's trade journals that are voracious for data like this because it's advanced, forward, innovative looking stuff. A lot of you may have a local journal, maybe your own hospital publishes a journal that you could put your data in. And then there's plenty of media outlets as well, local news, local newspaper, national opportunities as well. We've seen this all over the country now with local news supporting and interviewing your hospital at home programs. And so really, really encourage you to think of a strategy for publishing your data in one or all of these different areas. Because the more that people are talking about this, the more that patients are going to request this, the more that providers are going to request this, the more that payers are going to pay for this. And as Al so adeptly put at the beginning, people won't know how to be without home hospital by 2024. So I'm going to turn it over to Linda to hit up the next two action items. Oh, or to Al. Just kidding. Sorry, Al.
What David and Bruce and Ray, and Aaron have been talking about have been really important to help us institutionalize hospital at home and to show Congress, in 2 years that this is something that we cannot live without. Also important is being a good actor, playing by the rules. There is a time for going outside of the rule book. This is probably not the time to do that. There are many things that we can do with the capabilities that we acquire by being able to do hospital at home. Not all of those are hospital episodes, and they should not be billed as hospital episodes. And we should make sure that patients that we bill a hospital episode are meeting acute inpatient criteria. Additionally, it is inevitable that there will be escalations. It is inevitable that there will be adverse events if we're doing our job. But it's also important that we report these escalations and adverse events accurately and that we learn from them. To date, the rates of escalations and adverse events have been low and very favorable. We need to continue, doing the work and reporting on them and learning from them. In addition, David, touched on the need to publish and to get our work known. Not everything, that we publish, not all the ways of getting our names known are by, publishing data. Narratives, anecdotes, and testimonials are very powerful. They're very powerful to share with our colleagues for morale. They're very powerful to share with our referral sources. It's important to share these anecdotes and testimonials with our leadership, with our community to get ourselves known. It is important to share these testimonials with our representatives. And finally, we at the Hospital at Home Users Group are trying to create a clearinghouse of these anecdotes and testimonials that we can pull up when we need them. And I'm turning it over to Linda.
Hi. So I'm going to talk about the last two topics, which is pushing for contracts. And on my first slide, I'm talking about commercial and Medicare Advantage contracts. So we want this so we can increase the number of patients served by the model. It helps with the stability of the program post the current legislation. That is unknown what will happen after December 2024. And those contracts can be of many types. They can be acute only, DRG based, could be acute plus transitional periods, could be discounted of DRGs plus shared savings. All of those are really important for the stability of your program and to help the number of patients served. On our hospital home users group's website, the TA Center, we have some information on financial models to look at to help you think about those contracts. Another thing that I think is extremely important is to push for contracts regarding to Medicaid coverage. This slide is, I think, accurate about the states that have Medicaid programs that currently cover hospital at home: Arizona, Arkansas, California, Massachusetts, Michigan, Oklahoma, Oregon, South Dakota, and Texas. And then we have on the right side programs, states that we know that do not cover currently hospital at home or are considering or working on it. And all the other states we don't have good information on yet about those. This might seem daunting, you know, going to your state about this, but this is really, really important. Don't underestimate kind of the power of your persuasion, of you explaining how this helps with equity, how right now certain patients are not able to access this because your state is not covering it. So I think this is extremely important to move forward the field. And the last point is to act on equity and support caregivers. This may seem like a small part of your programs, but this is a huge thing. This is like the first question that comes out of those from Congress, from CMS, et cetera. Everyone wants to know how this is being considered in hospital at home programs. So make sure you're thinking about that you're tracking equity and caregivers. You know, how are you explaining the program to the caregivers or support persons of your patients? What are they actually doing in the home with your patients? And to emphasize again, what has been said by my colleagues is specifically in this area, study, publish, write up issues related to this. I have one article on the right here from August, which talks about family caregiver considerations for the future of hospital at home. And I would advise everyone to look at that. I think it has some really great points regarding this topic. So with that, I think I'm going to turn it over back to Bruce.
Thanks, Linda. So we thought we had so much to say that we were going to go on until 6 o'clock Eastern time, and I think we were able to get through it rather efficiently. So let me review some of the key action items from today. So number one, completing the program standards survey or completing the identification of someone who will complete the program standards survey for your hospital at home program. Very important. The link, the URL is there, the QR code is there. And as I noted before, we'll be posting this on our website, sending it out in Basecamp, and perhaps sending out a blast email as well. But this is really important so that we can ultimately make our case to stakeholders in the safety and quality space that our programs do meet, are, you know, somehow similar, somewhat delivering similar kinds of care, so that when folks say, well, you know, you've seen one hospital at home program, you've seen one hospital at home program, we need data to push back on that narrative. Use the span codes. We know that many on this call are not the folks who actually use them, but notifying or socializing your revenue cycle people, your coding people to the existence of these codes is very important. We think they're being underutilized, or we hypothesize that they're being underutilized because of simply a lack of knowledge of their existence. And if we can get those codes to be used more at higher prevalence, it will really facilitate our ability, independent of others, to be able to analyze data on what hospital at home is doing across the country. Coming back to David's points, publish quality data. It does not need to be in the New England Journal of Medicine local publications, research letters, anything that you can do, trade journals, really helps make the case. And it just contributes to an ongoing narrative that hospital at home is actually able to produce data and prove its value. Just the ideas that Linda was talking about a moment ago, the issues of equity and caregivers, extremely important to CMS. This is a very high priority item for the administration. There is some anxiety about whether hospital at home is putting excessive burden on caregivers, whether it can deliver equitable care. We know that early research and substantial research on the caregiver notion suggests that hospital at home does very well in these areas, but I think we need more data and to be attentive to this, again, to promote the right narrative, which is evidence-based. So I think with that, unless any of my colleagues have anything to add to action items, I think we can move on to the Q&A. So we've had some items coming through, and I may look at these and toss some of them to my colleagues. There's a question here from Ting Pun, who asked, are most patients using hospital at home coming through the ED? And I think in the context of waiver, patients who are being cared for under the CMS waiver, remember those patients do need to touch the hospital. Either they need to be in the ED and going from ED to home, or they start their hospitalization in the ED or directly admitted to the hospital and then continue to need hospital level care and then are transferred to the hospital at home unit. Much in the same way someone may transfer between an intensive care unit and a standard med surgical bed. So in the waiver space, yes, patients tend to come through the hospital and through the ED. Terrific question from Chris Antimpe that I'm going to toss to Ray and Aaron about any tools or tips for advocacy within our own states to promote the care model, specifically as it relates to Medicaid. And David Levine says he'd like to answer that question live. David, Ray, Aaron?
No, Bruce, I was trying to help you moderate the Q&A. We can first hear from our Healthsperien colleagues. I'm happy to pitch in.
Great.
Thought you were taking it for us, David. So no, great question. Happy to share some additional background, but first and foremost, reaching out directly to the state Medicaid office and sharing your experience. But really, as Linda was saying, making the ask is the first step. Oftentimes, depending on which state it is, some aren't even aware that they can offer it, and it's just making them aware that it's happening in Medicare. And in order for them to maintain equity, they will easily say that yes, that they're happy to do so. That's a great case to make if they're pushing back at all, that they want to provide equitable access, and so they should offer it. So that's one, but we can provide some additional talking points, certainly. But a lot of the points that we've made on this call in terms of the data that's available and in terms of the same arguments that we made to extend the waiver itself within Medicare can be translated to Medicaid. David, anything else that you want to add?
Yeah, thanks, Ray. The only other thing I'll add is the American Academy of Home Care Medicine, in conjunction with Healthsperien, has created a one-pager for this as well. And so, we can definitely send that out after this webinar. It's basically like that single fact sheet that you could go to your representative or go to your Medicaid people with, and you don't have to make it yourself. It's kind of already there. And we would highly recommend using that as a starting place for your talking points and something to leave with the representative or the Medicaid officer or who have you. But yeah, I think you'd be amazed at the power that you all have in approaching your representatives, your congresspeople, as well as the payers around you. And we've tried to create some of those tools already for you. So we can definitely send that out if that's not already at people's fingertips.
Great. I see a question from Danielle Martinez McCormack, and I think this might be a good one for Linda. Question is, can you speak a little bit more about trends in negotiating commercial contracts? Some of our peers share that they have negotiated contracts with the top 1 to 2 payers in their regions to reimburse at parity for the next 2 years.
Well, I'll start off that I'm not an expert in negotiating contracts. However, that is true. I think that there's a number of payers out there that are willing for the 2 years of the legislation, or previously prior to legislation, as long as the PHE and they were a waiver approved hospital, are willing to allow DRG reimbursement for the acute phase of care. But much of that is tied to the legislation. And so therefore, for long-standing, to kind of give you more stability, because we don't know what will happen after December 24, I think it's also worth going down the road of negotiating a contract that would last longer than that. And so that's where I was alluding to. There's probably a number of ways to do that. Going forward, it could be, again, still DRG based, or discount on DRG with some sort of savings based on metrics that the payers are interested in discussing with you.
Thanks, Linda. A question from Sumya Ragarjan, and it's a question that comes up not infrequently about, is there any way to change the ED/inpatient to home requirement? Notes that they've had a great success with direct admissions who are not strict Medicare patients and have other payers. So it's an interesting question. Our sense is that the ED requirement, when the waiver was implemented, was one of the ways that CMS thought that they'd be able to ensure, A, that the patient treated in hospital at home was more likely to meet leveling criteria for an inpatient stay, would have been more likely than if direct admitted, perhaps, to have the full diagnostic workup that the ED tends to facilitate. And it would also create that link between the hospital and the program within the hospital. And I think that my sense is that they have been satisfied with that requirement. So in terms of changing it, I don't know that they would be open to that. I can't speak for them, obviously, but my sense is that they find value in that. We're aware of models like yours that sometimes bypass the ED, direct admissions from home or from clinic, and I think there's a role for that. But my sense is, I'd be curious to hear from my colleagues on the call. My sense is that they will likely want to stick with that. Again, we can't speak for them, but I wonder if David, Al, or Linda have any thoughts on that.
I agree, Bruce. I think that is kind of where the tea leaves are right now. Who knows where they may be in the future? And to be very honest, I think we need some high-level evidence from the programs that are doing this model to publish their data and show those. I really do think that CMS is craving data on these different pathways. And if we, as a community, can show them the safety, the quality, the 30-day readmission, the escalation rates associated with models that bypass the ED and the general medical ward, I think they'd be more than willing to listen and to look at that in the future. And so for folks out there, hospitals, companies, primary care offices, anybody doing that kind of a model, super encourage you to, write up your data, show everybody what's going on under the hood a little bit. I think it will be extremely influential to having policy change in that respect, because to be very honest, the vast majority of current evidence base starts in the hospital. It doesn't start in the home. And that's not to say that we are not extremely excited about that kind of a model. We think it makes sense clinically in many respects, but that has not been the trial protocol or even the real life protocol for the existing data set so far. And just to answer another question in the Q&A, if it's okay, Bruce, somebody asked, how does the users group feel about programs that don't use the waiver? We are extremely excited about those programs. Anybody delivering high quality, safe, acute care at home is fantastic. We are extremely excited about that. And we know that there's many programs across the country that have chosen not to use the waiver because maybe their model is straight from the home, or maybe their model doesn't involve Medicare or Medicaid members. And so we are very encouraged by it. In fact, that's part of the reason for the minimum data set project, is to be able to obtain data on patients who aren't going through the standard mechanism. That is one of the reasons that we are hoping to get data together as a whole community so that we can start to paint that picture altogether.
Thanks, David. Another question, slightly different topic from an anonymous attendee. Is there any information available about the success of these programs? It just moved on me. About the success of these programs for hospitals that serve an economically challenged community or those hospitals dealing with social determinants of health. Al, do you want to comment on some of the research that you led with the CMMI demo and the outcomes of those studies? So Dr. Sue and Linda led a Center for Medicare and Medicaid Innovation demonstration study of hospital at home at Mount Sinai in New York. As I recall, 40% of the people treated in that program lived in public housing in New York City. And we had data available on the Medicaid eligibility status of the folks who received the care. Overall, in that study, readmissions at 30 days and ED visits at 30 days were reduced in half. And actually, when we looked at those data by Medicaid eligibility status, the benefit actually accrued more to those who were Medicaid eligible. So, you know, there's not a ton of research yet on equity issues in hospital at home. That's one small signal, and that those data have been published, and we're happy to provide the reference for that if that would be helpful. Also believe, and David can correct me if I'm misstating this, there are data from the Atrium program in North Carolina where, David, they looked at the outcome of escalations, I believe. And I believe there was no difference by different racial and ethnic groups. So it seemed to be equitable in that context as well. But we definitely need more research on the equity issue. It's something that the users group is involved with additional support from the Hartford Foundation, as well as a caregiving issue.
I could answer about the CPT codes.
Please.
Which I think is, so the question about CPT codes, I think that's really getting at professional billing. And so that would be, they're not unique codes. You would use the same inpatient professional billing codes, you know, the level 1 through 3, or the, you know, advanced care planning, or any of the codes you would use as a provider on the inpatient setting you would be using for hospital at home.
Thank you, Linda. A really good question from can you comment on the potential viable reimbursement models that you see when and if this program becomes permanent? I think that's a bit of the $64,000 question, or maybe $1 billion question. I would appreciate any help from my colleagues, but I think there are several potential ways to think about this. Pre-waiver, Al and Linda and I and folks at Mount Sinai worked on a proposal to something called the Physician-Focused Payment Model Technical Advisory Committee to the Secretary, and that was that's a committee at the Department of Health and Human Services. It's something that came about in the wake of the Medicare bill in 2015, and it allowed folks to come and make a proposal to HHS for new payment models of any sort in Medicare. There was about I think we spent the summer of 2016 writing that proposal. And what we proposed there was a small discount on the DRG and a bundled payment for hospital at home care plus 30 days post-acute. Reconciled on the back end for quality, anti-cherry picking measures, the whole bit. It made it through that committee and then made it to the desk of the secretary as various secretaries were cycling in and out of HHS. So one approach is this notion of a bundled payment. Our sense is that in general, CMS has been less attracted to bundled type payments lately over the last few years, partly and completely understandably that it becomes hard for them to administer multiple different kinds of bundled payments for multiple subpopulations within Medicare. So I think many of us would think that a strict DRG volume-based mechanism for payment is not the most value-based. And I think, what kind of value-based models emerge remain to be seen. And I think if folks have thoughts about that, feel free to send your ideas to us, and we can use them in our discussions with stakeholders. And David, Al, Linda, I don't know if you want to add to that.
I think it's really well said, Bruce. And this is going to be a very interesting year for the whole community kind of talking about those different payment models. There are lots of options on the table, everywhere from, like you said, Bruce, a bundled payment to an old-fashioned DRG to even per diem rates, right? So I think there's lots of options, and it's going to be some great opportunity to kind of talk these things out and look at the pros and cons of all the different payment options right now, as well as what's politically palatable. Maybe we all want one thing, but can only make another happen, given just constraints in the system.
There's a question, maybe Linda, what are your thoughts on the 2 in-person nurse visit requirement?
So so that I think is become kind of the standard now with Medicare, having stated that for the waiver and now the legislation. And I think that in the CMMI demo that we did at Mount Sinai, we did not have that requirement, and there were some conditions where there was a reason why maybe there weren't 2 in-person visits. I think it will be hard to roll that back to now that that's kind of out there. And so I think it's good to have those touch points for the patients, but I do think it's going to be hard to roll back.
There were a few questions on soliciting our thoughts on whether the model should or could expand to include observation.
Yeah.
Here, Linda, I don't know if you want to comment, or David. Linda, I know you did that during the CMMI demonstration, but maybe both of you could comment on that.
Yeah, I'll just start. I saw that question. I think it's a great question, and I think it's been an area of confusion for a lot of folks. There, as many people know, there are essentially 2 separate waivers in operation. They will both go away very soon. One of them was a blanket waiver that was actually afforded to all hospitals automatically during the pandemic, the Hospital Without Walls waiver. And that actually does allow for you to bill observation level care in a patient's home. Many hospitals were not aware of this, didn't quite know how to execute on it. That waiver is still there right now. The acute hospital care at home waiver, not a blanket waiver, as many of us know, a waiver that you have to essentially earn or demonstrate to CMS that you can deliver this kind of care through a very meticulous system that they have to essentially grant that waiver. And there you cannot bill observation level care. That is only acute care. And so I think that option has been there for observation level care. Lots of home hospital programs provide observation level care. And so curious, Linda, kind of to get your follow-ups to that.
Yeah, and so as you said, that that under the current original waiver will go away, on May 11th for the OBS. I think there has been some uncertainty about then the transfer if someone converts from OBS to inpatient, and where that H&P has to happen, which is some of that challenges, I think, that where that OBS at home under the original blanket waiver had kind of low uptake. I think it's something that we should push for. There is more and more, especially because more and more Medicare Advantage plans are requiring many conditions to start in OBS and then convert, that hospitals are then doing very similar for their Medicare fee-for-service patients. And so there's a lot of patients who are therefore missing out on the opportunity to go into home hospital. They do 2 nights in OBS, convert, and now you're like, well, they're 24 hours. Should I convert them to a hospital at home for that, or just keep them where they're at? And so I think they've now been 3 nights, and they could have been 3 nights at home. The payment's the challenge, but I think that is something that eventually should be included.
I think it's a great point. And just to piggyback on this concept, I'm just looking at Suresh's question about the span codes again, if it's all right, Bruce. Just to clarify, this is not something that a provider or clinician does. It's something that on the back end, your revenue cycle folks apply a span code when they bill. And so this is really a conversation that a medical or clinical director needs to have with the revenue cycle and billing department to make sure that they're applying that span code appropriately, just the same way that there's span codes for the ICU, there's now span codes for hospital at home. And so using it appropriately is all about the billers and coders knowing about it. Has nothing to do necessarily with the provider or the clinician, sending their professional services in. I do know that some institutions have tied span codes to place of service, and that's kind of a nice automated way they've done that. And sometimes the provider chooses the place of service. So maybe that's one way that you could essentially trigger the span code, Suresh. But in general, this is a back-end deal, and we've noticed that lots of back-end folks aren't aware of this code right now.
Great, thanks for that. There's a question, are most hospital at home providers part of an existing system? Are they working through their electronic system for care and reporting, or are there contracted ones? And then if so, how do you sync those systems? My own sense is that most programs are using their hospital system, conceptually thinking of the hospital at home unit as a virtual unit of the hospital. Would you agree with that, Linda, David?
I think that's how most programs are today. I do think that there are some programs that are using the EMR and the support of the hospital, risk, and how they talk about any concerns with the program, but they may specifically contract out staff for whatever reason, just like there are nursing shortages, or maybe they're having trouble staffing physician hospitals. They may use outside companies to staff, but they're still, in essence, just like staffing a specific unit of a hospital. They're doing it in that way.
Great. And then maybe the last question, and then we'll transition off the webinar. What keeps you up at night as leaders of hospital at home programs?
I was gonna say, I think one of the things that Al brought up earlier, a bad actor or a bad event that's spun out, that may not be because of a bad actor, but a bad event that gets spun out in a way that is not helpful for the field.
I think something that keeps me up awake at night is there's a I think there's an incomplete understanding of the range of home-based care models in hospital leadership and among the public. And I think sometimes the different models get conflated, and sometimes that does not help us with hospital at home. David, what's yours?
I guess I'll answer it. I think you guys did nicely. I share those same fears from kind of a national perspective. I think as more of a local perspective, I think, we're always worried in medicine about our patients that don't do well, and that medicine is messy and things don't always go to plan. And so the same way, whether I'm attending in the office, in somebody's home, in the hospital, I think I'm always worried about the patient that doesn't do well necessarily, and maybe even crashes. And so that I think keeps me up, whether they're in the hospital or in their home. And fortunately, we've created a whole bunch of systems and structures in home hospital now that I think really don't keep me up as much anymore at night, worrying about that. We have a whole bunch of predictive analytics, sensors, things like that, but that I think still bugs me from a very local perspective, which maybe hopefully is helpful.
No, that's great. And I think that'll wrap it up for the questions. Just a reminder, Al mentioned at the top of the hour, but the Hospital at Home Users Group meeting, which will be a virtual meeting on the day before the in-person meeting of the American Academy of Home Care Medicine. So we'll be virtual at the users group, the in-person American Academy of Home Care Medicine meeting in the great city of Seattle, October 12 to 14. And if you want to submit a session abstract, not a poster, but a session abstract for the Academy meeting, the due date is next week, and there is a hospital at home track for that. We encourage you to do that. A list of all the webinars, we will be adding this one to that list. And the slides and recording should be on our website by the end of the week. And I think that wraps us up right on time. Thank you all for participating. If you have comments, questions, feel free to send them along on Basecamp or an email. And thanks for all that you're doing for the community and for the cause. Take care.